So the next speaker is Dr. Josue Chaco. Could I please ask Josue Chaco to put up his slide? So Dr. Josue Chaco, you're going to speak about ultrasound evaluation of the lung.
That's correct, yes. I'll just switch on my slideshow. I hope it is moving for you.
Yes.
Okay, that's fine. So it's a real pleasure to be here, as always. So we are in the middle of a worldwide crisis, as you know, with COVID-19 breaking out in an exponential fashion across the world in many cities, including Bangalore. And that's a time when you look deep at what ultrasound of the lung can do for you to help your patient by the bedside. Just imagine you're in a COVID ICU, middle of the night, your patient was hypoxic to begin with, he's on a high FiO2, and then you find that things are going rapidly downhill. You're standing there watching by the bedside as the saturation slides down from 90%, 85, 80, and so on. And you're unsure as to what's going on. And you need to do something, and you need to do something pretty quickly. Of course, conventionally, we would ask for an X-ray, but at the best of times, getting an X-ray done, viewing it, and taking action is going to take at least half an hour in most centers. That's precisely the situation in which ultrasonography can be your real friend, wherein you can use this modality by the bedside to evaluate what's going wrong with your patient that made him severely hypoxic. So let's look at the hardware that you need to look at the lung. In fact, if you want to look at the lung, you need to ask the question, what do I want to look at? Is a superficial image enough, or do I need to look deep down into the lungs? And the probe that you choose would depend on where exactly your focus of interest is on. This microconvex probe is a very useful tool, particularly for ultrasonography of the lung, because it wedges nicely into an intercostal space, and you can get a very clear-cut view of most areas of the lung. And it's got just the right frequency to allow you to see superficial as well as deep structures. It's got a frequency of 8 megahertz, as you can see here, and it's a very valuable tool to have a comprehensive examination of the lung. So for convenience, like when you auscultate, you divide the chest into several areas. Ultrasonography also is based on 6 zones, as you see here. This is to ensure that you cover all areas of the lung and you miss out on none, particularly these posterior zones, which are very important, especially patients with intubated patients in ICU. They develop changes first dorsally and also towards the lower zones of the lung. So these are 2 areas which you would not want to miss if you are in an ICU. And very important to emphasize that many of the changes in COVID-19 pneumonia also begins posteriorly. So that's the importance of ensuring that you do scan through the posterior aspects of the lung very importantly. Let's begin by intubating our patient. When you place the probe at the level of the neck, I've placed a linear probe. This is a 12 megahertz probe. This is a view that will be familiar to most of you. You can see the trachea here. And just to the left of the trachea, you can see the esophagus very clearly. And if you swallow, the esophagus becomes very prominent. So when you intubate, it's a good idea, if you're not sure about passing the tube first time round, or if you expect difficulty, to look at the neck with a linear probe. And what would you see when you do that? You will see the trachea, you will see the tube come down, and let us see what's happening here. As you can see on this image, you can see the trachea and the esophagus by the side. But on this image, unfortunately, the tube has gone down into the esophagus. And what you see here is what gives you the appearance of a double trachea, 2 tracheae lying side by side, only because the tube has gone into the esophagus. And if you see an image like this, there is no more confirmation required. You pull out the tube and pass it into the trachea. So, and the next step, once you intubate, normally you would use your stethoscope to make sure both lungs are getting ventilated, but you have the machine booted up, ready by the bedside. There is no better way to confirm ventilation of both lungs than ultrasonography. And if your tube is in the right place, this is the image that you get. In fact, this is the basic lung image that you would look for, starting from superficial to deep. The probe is placed with the probe marker pointing to the head of the patient. And from superficial to deep, you see subcutaneous tissue, fat, the pectoral muscles. These are all, if you see, they're all static. There is no movement that you can appreciate, or hardly any movement. Then you come down to the first thick white line that moves from side to side with each respiration. This is the pleural line. So this is the basic view that you need to get to make sure the lung is expanding on that side. And if you see this movement, the pleural movement from side to side, that means the lung is getting ventilated at that point. So you visualize the lung on one side, and then you move on to the other side and ensure that the pleura is sliding from side to side on the other side as well. Now, suppose you see an image like this on the right side of your screen. You can see the rib shadow there. You see the pleural line, but the pleural line in this case is not moving. If the pleural line is not moving, it clearly means that the lung is not expanding in that particular area. And you may get sliding on the right side, you may not get sliding on the other side. It just goes to show that your tube may be in the right main bronchus, especially if you push it too far inside during intubation. So watch out for pleural slide. If you see the slide, it means that's good. The lung is expanding there. Now, this is an image of my own lung, which I imaged with a 8 megahertz probe that we saw earlier, the microconvex probe. And starting from superficial to deep, there is nothing moving there. You see the pleural line, it moves from side to side. I'm breathing in and out, so it moves from side to side. Now, this is a patient who came to us with breathlessness. He was end-stage renal disease, had missed a round of dialysis the other day, and he came to us feeling very breathless. And that's his image. You can see the pleural line, but compare it to my own pleura and lung on this side, there is a distinctive difference. You see several laser-like lines which start from the pleural line. They move side to side with the pleural line, and they go right up to the bottom of the image. So if you see these kind of lines, starting from the pleural line, radiating like laser beams from the pleural line and moving with the pleural line, extending right up to the bottom of the image, it means they are B lines. And B lines indicate that there is interstitial fluid or intraalveolar fluid at that particular point. Now, this may be due to many different reasons. It may be due to interstitial edema, pulmonary edema, cardiac failure, fluid overload. It may be due to consolidation. It just means there is extra fluid there, which shouldn't be there normally. So that's what you see there. And then yet another patient, he was more profoundly hypoxic, saturating only in the 70s on room air. And if you compare this image to the image here on this patient who's more severely hypoxic, you will see that there are B lines here as well. But what's happening to those B lines? They are much, much thicker. You cannot, in fact, make out individual B lines. They're all merged together, or it's a conglomerate of all B lines merged together. It's actually an ultrasonographic whiteout. It means there is intense amount of interstitial fluid in this particular patient, explaining the profound hypoxemia that you get with the saturation of only in the 70s. So this is early pulmonary edema. This is quite advanced stage of interstitial lung edema. Sorry. Now, this patient, he came to us with fever and cough 3 days, and he was feeling some little bit of chest pain, finding it difficult to breathe. Saturation was low, and we placed the probe on the right base of the right lung. And this is the image that we got. As you can see, what looks like the liver, this is in fact not the liver. It is the lung tissue that you're seeing. And what do you see inside the lung? You see what looks like a branching kind of streaky white lines, branching streaky white lines within the lung that has taken the appearance of the liver. Or in other words, it is the radiological equivalent of hepatization of the lung. The lung looks like the liver because it has become solid, it is consolidated. And these white streaky lines that move back and forth like a tree branch are from air that travel within the bronchi, representing the air bronchograms on ultrasonography. So if you see an image like this is conclusive evidence that your patient has consolidation. On the image on the right side, again, you see white streaky lines in what looks like a solid lung. But if you see these white streaky lines, they are not mobile. They don't move back and forth like you see here. And that's because the lung here is collapsed. The lung here is collapsed, and the bronchograms that you get, the so-called ultrasonic air bronchograms that you get, are static. They don't move. If they don't move against the background of a solid lung, it means the lung is collapsed there. So this is consolidation because the air is moving back and forth. Here the air bronchogram is static, and that means the lung is possibly collapsed, in contrast to the consolidation that you see there. So just to recap, that is a normal lung. This is mild interstitial pulmonary edema. That is severe pulmonary edema with all the B lines merged together. And this is the typical picture of air bronchograms that you get in a patient with consolidation. What other features that would you look for, especially as I mentioned in this COVID era, to look for consolidation? Now, this is the X-ray of a patient who presented to us with suspicion of COVID. As you can see, the X-ray itself is pretty much not very conclusive. You can see some streaky shadowing on the right side, but it's definitely not conclusive of consolidation. But if you look at the ultrasonography, that is starting from superficial to deep, that's a pleural line, and you see breaks in the pleural line. Like you see here, if you watch closely, the pleural line moves back and forth, but there are apparent interruptions to the pleural line. These are breaks in the pleural line representing consolidation. This is in fact quite significant consolidation, which was shown very clearly on the CT scan. So that's how important ultrasonography can be in the early diagnosis of COVID-19 pneumonia. And particularly, as I mentioned, you need to look posteriorly. That's where the changes happen first in COVID-19 pneumonia. Now, we saw this image previously. The pleura is sliding nicely here. But this patient, he underwent a central venous cannulation of the subclavian on the right side. And shortly after the procedure, when we looked at the lung, it looked like this. The pleura here was not sliding, and his saturation dropped slightly from the 90s to down to the 80s on an FiO2 40%. So that's a very strong suspicion of pneumothorax. So when you see absent pleural slide, one of the differential diagnoses is pneumothorax. Is it a specific sign? Not at all. Absence of lung slide could mean several things. It only means the lung is not expanding in that particular region. It could be because of, as I mentioned, right main bronchial intubation, you won't get any sliding on the left side. Or it may be a collapsed lung, which may give rise to a static pleural line. But here in this case, there was a strong clinical suspicion. So lack of pleural slide is highly sensitive for pneumothorax. but it is not specific. Now let us look at what may be the specific sign on ultrasonography of a pneumothorax. It is what you see here on the screen. That's the pleural line starting from superficial to deep. You see the pleural slide extends up to a certain point, and beyond that, the pleural line is static. If you watch closely here, the pleural line slides up to the end of this green line, and beyond the green line, where you see the red line, there is no pleural slide. So there is a junction between the pleura that is sliding and the pleura that is not sliding, shown by the arrow here. So that is actually called the lung point. The lung point indicates the junction between the pleura that is sliding and the pleura that is not sliding. And if you see this on ultrasound, there is only one diagnosis. It is pneumothorax and nothing else. So that is a specific sign of pneumothorax. It is not very sensitive, but in many patients, if you start moving the probe from lateral to medial, if you move laterally, you won't see pleural slide, but as you move medially, the slide may start appearing, and then you may be able to see this junction between the sliding and the non-sliding lung called the lung point. And you can switch on to M mode view as well. The M mode gives you a typical what's described as a barcode sign, in contrast to the C and seashore sign that you get with a normal lung. So that is normal lung. This is a pneumothorax on the M mode. Now, what does this patient have? The probe in this case is placed on the right hypochondrial area. You can see the liver, that's the liver. This thick white line is the diaphragm. And what you see here is the collapsed lung. And all around the lung, you have plenty of hypoechoic shadow that represents pleural effusion. So what do you see? You see the liver, the diaphragm, the lung, which floats in the fluid, floats in a huge amount of pleural fluid. So that is a typical picture that you see in pleural effusion. And if you want to drain it, you can do it very well under ultrasonic guidance. Once you pass the wire, you can make sure that the wire is actually in the right place. The wire is placed above the diaphragm. And that way you prevent poking below the diaphragm into the abdomen, which has happened. So you can avoid all that if you are guided by ultrasound. And if you want to measure the volume of pleural effusion, again, it's a simple thing to do. So here you have the collapsed lung, that is the chest wall. You measure the distance between the visceral pleura and the parietal pleura. The visceral pleura lines the lung, the parietal pleura lines the chest wall. You measure that distance, and the volume of pleural effusion is given in ml by the interpleural distance. That's the interpleural distance between the visceral and parietal pleura in millimeters multiplied by 20. So if you get, say, 5 millimeters difference, or let us say 5 centimeters difference, it'll be 50 millimeters. The volume of fluid will be 50 multiplied by 20 will be 1000 mils or 1 liter of pleural fluid. If you want to be that precise, this is a good method, but generally speaking, you can eyeball it and get a rough guesstimate. That should be good enough. Now, what happens when you have a patient who is profoundly hypoxic, but on ultrasound and on radiological imaging, the lung looks like it is normal? That's when you go through your algorithm and look at the heart. Echocardiography becomes very important. And what do you see here? That's the left atrium, left ventricle, and you can see the right atrium and the right ventricle in this case is quite significantly dilated. And you can see that the LV apex is the right ventricular apex is contracting very well, but the rest of the right ventricle is not contracting as well. That's the apical sparing that you get, a typical feature of acute pulmonary embolism. So normal lung with a dilated right heart, strong suspicion of acute pulmonary embolism. So just an easy mnemonic for you to remember what is the algorithmic pathway that you go through to look at the lung. ECPCM is a short mnemonic. These are the conditions that you look for: pulmonary edema, consolidation, pneumothorax, collapse of the lung, and pulmonary embolism. So that is pulmonary edema, plenty of B lines. Consolidation is characterized by break in the pleural line as well as air bronchograms, as you see. Pneumothorax is characterized by lack of a pleural slide, which is a highly sensitive sign. And the specific sign is the lung point sign, where you get the junction between sliding and non-sliding lung. In a collapsed lung, you see a tissue-like density with static air bronchograms. That suggests collapse, in contrast to the dynamic air bronchogram in consolidation. And then if you have a normal looking lung, acute right ventricular right-sided dilatation with right ventricular dysfunction, that is strong evidence to suggest acute pulmonary embolism. This image is actually something that has been in our minds for a very long time. This young girl presented to us with severe hypoxemia, and she had severe ARDS. And then we did a bubble test on her, and that's what we found. There was a pacification on the right side, but there was quite significant opacification of the left side as well within the first 3 beats. So that is very strongly suggestive. In this case, she was on a high PEEP, high inspiratory pressures on ventilation. The patent foramen ovale had probably opened and resulted in a right to left shunt at the atrial level. So if you see this within the first 3 beats, that indicates a shunt at the atrial level or through the heart. But if you get opacification of the left side of the heart after 3 to 5 beats, then it indicates an intrapulmonary shunt, which is common in hepatopulmonary syndrome in patients with cirrhosis. And it is very important to look for these days in patients with COVID-19, because there are several reports of patients with COVID-19 is in fact characterized by a very significant shunt within the lung, without much parenchymal involvement in the early stages. That's the reason why they become very hypoxic without much breathlessness in the early phase of COVID-19, because the parenchymal involvement is minimal. The vascular involvement is very profound, and there is a shunt within the lung. That gives rise to severe hypoxia, but the symptoms are not that much initially because the lung parenchyma is fairly well preserved. So in this situation, it's important to do a bubble test wherein you will get a pacification of the right side after 3 to 5 beats, suggesting an intrapulmonary shunt. That is something that you must look for. I have seen a study in which they detected up to 20% of patients who had this phenomenon in early COVID-19. So on that note, I will finish off, I think, and we will probably take questions at the end of the session. Thank you.
Thank you very much, Dr. Chaco. I think that was absolutely brilliant and succinct presentation of lung ultrasound.